questions about just logistics or assignments? Okay, so today we are going to cover how we measure disease occurrence, some of the measurements we do, cross-sectional studies, and ecologic studies. And we'll go through, each of these throughout time. I just want to start with one follow-up from your lecture last week. So during August, Westchester County, which is just across the water from here, the health department there got reports of 12 new cases of tuberculosis and 12 new cases of aseptic meningitis. So we know that tuberculosis isn't a seasonal disease. There's not really any seasonal pattern that's ever been seen. But aseptic meningitis is caused by a viral infection, and so usually it peaks somewhere between August and October. So if you were working in the Westchester County Department of Health, what do you think you would actually, what would you need in order to determine whether you have an outbreak going on in your county of, first let's take tuberculosis. Yes? Right, and how are you going to get that? What is it that we talked about last week that helps us to keep track of what's usual patterns? Yes? Right, so you need surveillance data to look at this. And you need to look at them a little bit differently. So for the tuberculosis, you could just look at what does it look like in the past year, because it's not really supposed to change over the season. So remember when we had the slide last week, we saw that the rates went like this, and then if all of a sudden you see this in August for TB, then you know that you probably do have an issue going on there. If, on the other hand, you see something like this for the aseptic meningitis, you would want to compare that to last year, like you said, because that's one that might peak in August. So if you see that traditionally in last year and the year before, then you would be a little less concerned. So I just bring this up to remind you that you always have to be thinking about, what should we be comparing our data to? We can't just say this, wow, we've never had 12 cases in a month, we must have an epidemic. If you just started working there in the past 6 months, you wouldn't have known that last August, in fact, you did have 12 cases of aseptic meningitis. So it's important to have something to compare to in order to know what you're dealing with now. The other infectious disease thing that actually happened within the hospital I work in is one of the departments, someone went to fax something and all of a sudden something fell on the piece of paper and she squished it and a lot of blood came out. And so we called in the nurse for employee health and she determined that it was a bed bug. And so now they're trying to figure out where did this bed bug come from? How can we stop it from spreading to other people? Who might have been the source? So we have our own little epidemiologic investigation going on there that is more similar to the infectious disease kind of thing. And so what you need to know for that is, well, how long this happened on Monday morning. So how long can a bed bug last, and how long would the blood supply still be fresh? I'm sorry to be gross, but that's what happened, where it just made a big splat on the paper. And you need to know all of these things, because if it only is going to last 12 hours, and you're only looking at anyone who was there Monday morning because the place was closed on the weekend. So, these are the ways that you need to think about when you're trying to identify the source of whatever is going on, or to just figure out whether you have something going on at that particular moment. Any questions? Okay, so in general, in epidemiology, we're studying a population, and we know that as a disease progresses, it's going to impact fewer and fewer people, and knowing this will impact our study design. So we could have different levels of illness here, where you have the total population. Some of these people might end up being sick, but you don't always go to the doctor if you're sick, so they might just be sick at home. Of those, a fewer proportion are going to actually seek care. They're going to get medical care. And of those, a few more are going to be more serious, where they might be hospitalized. So if you're doing a study at each of these levels, you have to think about, well, who am I missing and who am I going to get in my study? And is it a situation where everyone is always hospitalized? I do a lot of work with osteoporosis. So when we study hip fractures, it's easy. Everyone goes to the hospital. But then when we also want to look at spine fractures, it becomes much more difficult. Many women and men will have a spine fracture and not even know that they did. We've had people that come to our hospital and they've lost 5 inches of height, all from multiple spine fractures, never felt any pain, never knew anything. And so those people basically were never, considered sick, never sought care, never hospitalized. So if we want to study spine fractures, how are we going to do that? These are the kind of issues that you need to think about if you are designing a study, and also if you're reading a study, you want to understand a little bit more. If someone does a study and they're only looking at hospitalized people, how are those people different from all of these other people? These are the ways that I want you to start thinking. The other thing is that people will die in each of these segments of the population, but probably a greater proportion of the hospitalized will end up dying. And all of that will impact when you're doing a study, where you get the data from, where you get the people that are involved in your study from. So in order to measure disease, we really need to understand the natural history of the disease. We need to understand what happens from someone being healthy to then they might have the disease, but they might not have any symptoms. At some point they get the symptoms, some later point they might seek care, then the doctor actually figures out what's wrong, they get their diagnosis, and then they might get treatment. And there's multiple outcomes that can occur. In some cases they can be cured. If they have an infection, say they had strep throat, they were given antibiotics, they're cured after that. In some cases, it might be controlled. If someone has diabetes, you're not going to cure their diabetes, but hopefully you can control their blood sugar. They could end up with a disability. If someone has a stroke and they go for physical therapy and everything, but they still can't really ambulate, then they would end up with a disability, and then you're thinking about, well, what services would they need? And then lastly, some people might die. So that's what you're thinking about at the patient level, and many of you might go on to medical school, and that's what you're kind of thinking about. When we're doing a study, we have to think, okay, what are the sources of data we have, and how are we going to capture people at each of these levels of wellness and sick? So you start out again with healthy people. If you're doing interviews, no one is going to tell you that they have an issue unless they already have symptoms. So if it's a disease with an asymptomatic preceding portion of time, you're not going to know about that person. If you ask them 6 weeks later, maybe in an interview would know that they had symptoms. And then also if they seek care, then you're going to capture them not only if they are asked during an interview, but also if you're basing your study on physician records. Many times we go to doctors' offices, look at the records, and try and get information, and that's how we do our studies. And then if people go to treatment and they actually need treatment within a hospital, then you could maybe use hospital records. So how are we going to measure disease is going to vary, and depending on which point in time we want to get these people, it'll matter. If I'm doing a screening program, which we'll talk about later in the semester, and I want to screen people for diabetes, I obviously do not want to wait until people have symptoms. Many people don't. And so I want to try and get them right around the disease onset. So what's a good way to capture these people before they get to the point where they might be seeking care or having symptoms? And so then you're interested in this part of the pathway. So you might want to say sample the population for hemoglobin A1C to try and get that information. So all along this timeline is different ways in which you can capture your study population. And in each of these ways you capture it, you're going to miss some people or get fewer people. Obviously, if you go all the way out to the hospital records, your amount of people that you're going to capture in your study will be less. So we just touched on this a little bit last year, but one of the important measures we want to think about is what is the rate of disease. And the source of data that we use is going to influence the rate of disease we measure. From the last graphic, if I did the rate of disease on the basis of interview or on hospital records, what would be the greater rate of disease? Where would I get that from? You might get it from interview, but in part it's a trick question. You'll get more people there, but you also have a larger denominator. So whether the rate will change or not, we don't know, but we'll capture more people that are actually sick through the interview than we will through the physician records or hospital records. Rates can help us understand how fast the disease is occurring in a population, whereas proportions really tell us what fraction of the population is affected by whatever disease we're interested in. So a rate, just think about it in terms of it's a ratio that consists of a numerator and a denominator, and time forms part of the denominator. And that's the important concept of rate, that you have to have some concept of time. So it's not only going to have the disease frequency, it's going to have an idea of what the size of the population is. And lastly, you're going to have some kind of a time period during which this event or this disease occurred. And so all of these are needed in order to think of a rate. So if during class today I ask each of you, have you ever had the flu? Can you raise your hands if you've ever had the flu? Okay, so we're up about almost 95%, I would say. Okay, is that a rate? Why not? There's no time period. It's just have you ever? And, you know, that's different than, now what about if I take this class and I say, okay, during 2013, 2014, during your time here, I want you to email me if any of you get the flu. Could we get a rate from that? We could, right? Because we have how many cases you're going to tell me, and we have the denominator, all of you in the class, and we have a concept of time because during the next year we're looking at that. So it's kind of a simple but important concept that I just want you to be aware of. So one of the other thing is measures of morbidity or sickness. And these are very important because we don't want to do our studies on mortality and only capture, you know, things that kill people. We want to try and get people earlier in the disease process. So the incidence of a disease is the number of new cases of a disease that occur during a specified period of time in the population at risk for developing the disease over that period of time. So it's a measure of risk for a defined population over time that the population was followed. So saying that it's got to be new cases, it would be males that had a new diagnosis of prostate cancer and then divided by the population at risk. So if I was calculating this for New York City, would it be the whole population of New York City? Why not? Pardon? Right, you don't want to include women. They're not at risk for prostate cancer. So it's got to be new cases, and the denominator has to be who's at risk. And that's an important concept. Again, it sounds kind of silly and almost simple, but you'll see when we go through some examples that sometimes it can be an issue. And usually because disease, like unlike the flu, when 95% of you have had it, if we're looking at, say, cancer rates, we usually are multiplying by 1,000 or 10,000, and then we'd say that's the incidence per 1,000 people or the incidence per 10,000 people, because we don't want to talk about a portion of a person that got disease. So instead of 0.021 per 100, 0.021%, we're going to say 21 per 10,000. So the incidence rate uses as a denominator the sum of different times that an individual was at risk, or a concept called person years. And I'm going to explain this graphically on the next slide, and you might have already seen this in some of your readings for readings. Person years vary based on loss to follow-up or for various reasons. And you need this in order to calculate an incidence rate. And an incidence rate is really a true measure of risk, but you can only calculate this in certain study designs where you're going forward in time. Things like a cohort study we'll talk about in 2 weeks, or a randomized controlled trial that we'll talk about in 3 weeks. So here's the concept of person years of observation. So on the y-axis, I have 5 people. This is person 1, person 2, persons 3, 4, and 5. Now, each of these people, I'm following up over a certain period of time. As it happens, no one dropped out of this study. It's a wonderful study. They all stayed in, all 5 of them, for the 5 years. So what happens is our total person years for this group is going to be 25, because each person is contributing 5 person-years of follow-up. So all it is a combination of a person and how long they were followed. So if you look at, say, some of the Framingham studies or something else you might read in a cohort study, they usually are talking about how many person-years did they accumulate in that study. And it's usually a pretty large number. You might have 1,000 people, but they might have been followed up 20 years. And so you're getting up there in terms of the person-years. Yes?
If someone drops out, are the years that they stayed in counted towards the
Yes, they are. So that's an important question. So if someone drops out, say if person 1 only did the first 2 years, we're only counting those 2 years for that individual. So we'd only have 22 years of person-years of follow-up. So when someone drops out, we include them until the point in time they drop out. And a lot of times in a paper, they might have a description that says, you know, the person time was followed up until like 1998, or until someone died, or until someone dropped out. Like, they'll tell you what are the end points for person-years for each group. Any other questions? Okay, so prevalence is something different. And that's defined as the number of affected persons in the population at a certain time divided by the number of people in the population at that time. So during this lecture, have I talked about a prevalence rate? Not really. The one that's closest to it would have been the flu example, but that's if once you have the flu, you always have it. So instead, if I asked you, you know, how many of you have ever have been diagnosed with rheumatoid arthritis? I'm asking you, I don't care when it happened, I'm just asking how many have rheumatoid arthritis. That would be a prevalence rate. And that's some of what we're going to be talking about, the kind of studies we're talking about today. So when a community is surveyed, with you guys say being the community, to determine the prevalence of a disease, we don't take into account the duration of the disease. We're just asking, have you ever had? So it's not really a measure of risk. There's no time concept in there like you get with the incidence rate. So whether someone was diagnosed, so say asthma, that might be a better thing. You know, people get asthma and they really have it most of their life. It might be under better control certain times or not. And so we could ask, how many of you have asthma? And you'd raise your hand. And like my kids had it from the time they were 5. But that wouldn't matter as compared to whether you had just gotten diagnosed last year. You'd all be counted the same as someone who has asthma. Now, in terms of prevalence, there's also 2 ways to look at it. We can have either point or period prevalence. So the prevalence of a disease at a certain point in time is called point prevalence. So in other words, today I want to know what is the prevalence of asthma in this class. I could do that today. Period prevalence defines how many people have had a disease at any time during a certain period, such as during the whole last year. Or so you can actually have a time span during which you look at that. So I'm going to just go through a couple of mathematical examples to make it a little more clear. So with point prevalence, I'm asking how many people are ill divided by the total number in the group at a certain point in time. So the total number with arthritis in the group divided by the total number in the group, we end up getting 14.9% as the point prevalence. So that's just a snapshot. Think of these things, prevalence, as just kind of a snapshot. It's just giving you that one, what is going on right now in terms of how many people have been impacted. And so this is an example with arthritis and people in the group, and about 15% of the people have arthritis at that particular point in time. Period prevalence is shown here, and this is the number of persons that are ill divided by the average population during a time period. So it could be persons with asthma in 2008 divided by the average population in 2008. So in this case, there were 2,293 people that had an episode of, think of this as an episode of asthma during the year of 2008, divided by the population, the average in that 1 year that you're looking at for the period prevalence. And so there you can actually say 5.5% had asthma in 2008. But again, this is different than incidence because I'm not saying they were diagnosed with asthma during that. They're not new cases of asthma. They're just admitting to having an asthmatic episode during 2008. So are you clear on point and period? So how you ask a question when you're doing a study determines the measure you report. So if I'm asking you, do you currently have asthma? It's the point prevalence. I want to know right now, today, in this hot, humid weather, how many of you are having asthma? And that might be a different number than last week when it was clear and cool and crisp. You know, it's going to be a little bit worse today in terms of the point prevalence. We could have a period prevalence. The example I gave you before was for 1 year, 2008. But we could say during the last 5 years, how many of you have had asthma? So you can take any particular point of time that you want or period of time and use that. And then there's also cumulative or lifetime where it's more, have you ever had asthma? So just think that whatever measure you see, make sure it matches with how they said they actually collected the data. And it should all be kind of clear that is it a point prevalence period or cumulative. So thinking again about those number lines that we talked about before, I want to just use this graphic as an example of incidence and prevalence. So here we're going from January of 2008, May, all the way to December of 2000, from January till December 2008. Each one of these lines represents a person. And so if I wanted to know what is the point prevalence in May, it would be how many of these people, this is a person with a disease, so how many people in May actually seem to have the disease if I was doing a point prevalence in May? Yes? Right, there's 5 people. All of these arrows actually cross this line. So you have 1, 2, 3, 4, 5 people actually for the point prevalence. Now, if instead I wanted to know how many incident cases there were in 2008, can you tell me how many of them are incident cases in 2008? Yeah. Right. So it's people that were new during this time period. So this person and this person were new. These 3 already came into it with disease. So just remember, it's new versus existing is how you're thinking of incidence and prevalence. If we wanted to go back to the point prevalence in September, what would that be? Yeah. It's 3, right? Because you have this person, and this person. So, you know, it's just a graphical representation. Obviously, most of the studies you're looking at will not have so few people that you could put it on a graph like this, but just to wrap your head around how are we thinking about an incident case or a prevalent case and what is our timeline are very important. Now, there is a relationship between incidence and prevalence. So I'm going to start out with this graphic. So you have incidents or incident cases piling into this flask. This flask is all of the prevalent cases, but they don't all stay there forever because some people will no longer be a prevalent case because they either died or maybe they were cured from the disease. So that's the way that your prevalence will go up as you get incident cases. It will go down as people die from the disease or are cured from the disease. Yes? Okay.
If you asked how many points prevalences there are in January, does that have to cross the line in January, or can it start to?
So if you're doing point prevalence, remember that's like at that point in time. So it's anyone who is crossing the line on that line. So it would be 3 in January. Yes?
Are they all period prevalence?
So if you wanted to have period prevalence, all of these would count, because if you had period prevalence for 2008, all of these people existed with disease during the time period of 2008. Anything else? Okay. So again, if you have more cases being diagnosed, I just came out with this great screening tool for diabetes, and so I'm capturing more people with diabetes. What is going to happen to the prevalence? Yes? Right, the prevalence will increase because the incidence is going up. I'm capturing more people. If I have people with breast cancer and I've come out with this great cure where people don't end up dying, what is going to happen to the prevalence? Yes. Right, because they're not leaving that flask. They're not dying and leaving the flask. So when people talk about prevalence or how many cases exist, remember that these other things have to be taken into account. Sometimes people try and look at time trends and they compare, like, what was the disease rate in 2007 versus 2010? And you have to consider, well, was there any change in how we diagnosed people so we got more cases? Was there any new treatment that maybe we lost fewer people? Because you can't compare them if these events occurred. Yes?
In the breast cancer example you were talking about a new cure. Wouldn't that cause the prevalence to either stay down or go down or stay the same? Wouldn't they also be leaving the population with breast cancer if they're cured?
If you could say that they were fully cured, but for something like breast cancer, you never really say you're cured because there's always the chance of, you can say you're kind of in remission, but I think you don't want to say that you're totally cured because then people will stop going back for follow-up visits and oftentimes the cancer comes back. So you're right, if it was something that you could totally get rid of. The reason why I use breast cancer is because there is such a high rate of breast cancer appearing again. There was another question? Oh, okay. Great minds think alike. Okay, so insulin and diabetes. When insulin was first used, the prevalence of diabetes went up because it didn't cure diabetes, but it controlled it. So the people didn't die, so they weren't leaving the flask. They were coming in and they were never leaving, so that prevalence just kept on piling up. So in general, a new measure that enhances survival or improves detection will lead to an apparent increase in prevalence. And these are the kind of things you need to watch out for when you read the newspaper, because I think one of the examples was in the Women's Health Initiative, when the results came out about estrogen and potentially increasing the risk of cancer, a lot of women stopped using estrogen, and so the rates of breast cancer went down. And so people were trying to say, aha, it's because they went off of estrogen. And then other people chimed in and said, no, it's also that the recommendations for mammography have changed. And we have to take that into account because without the same rates of mammography, mammogram screening, we're not going to capture the same number of cases. So that's just an example of, thinking through and not just believing everything at face value, thinking about what else could come into the equation and actually make an apparent change that's not real. So in terms of prevalence, although prevalence can't be used to measure risk, that's really incidence we'll get at. Your risk of disease in the future is really based on incidence. But we do use prevalence, and a lot of times it's useful for public health measures. It'll help us to measure the burden of disease in the community. Again, to help with what kind of resources we need. If we know that there's an increase in stroke that's going on in the nation, we need to think about more rehab centers and places to try and get people moving again after their strokes. It helps in the planning of health services. If there's a huge increase in the birth rate, then all of a sudden you're going to say, okay, we need to have more vaccines and everything available because the age group that gets vaccines is all of a sudden booming. But really, to look at whether a risk factor leads to disease, we need to strictly keep at incidence rates. And that's like a key concept that I want you to keep in the back of your minds. So we can measure incidence, we can measure prevalence, and for either one of these measures, there's certain issues that can come up or problems that we have. And they are defined in part due to the numerator. So one thing is, how do we define who has the disease? And that might be simple, but how do you really define it? And I'm going to give you some examples to kind of make that clear. One of them is for rheumatoid arthritis, and the other one is for dementia. So This is criteria for whether someone has rheumatoid arthritis. It's not a very clear-cut thing. I've been with family members and people where they say, you know, you have rheumatoid arthritis, your blood work isn't coming back to say it, but I can feel your joints and I know clearly you do. And that's because of this list of criteria. So there's the American Rheumatism Association criteria, and there's 8 different things. And you need to have 3 of them to be a probable case of RA, or you need to have 5 of these to be a definite case of RA. So you can see that you don't need to have any serum positive for rheumatoid factor, but you can have 5 of these and still be considered to have RA. And it could be a mixture of many, you know, any of the 5 of them. Then there's also the New York criteria. And in that, there's episodes of 3 painful limb joints, there's swelling and different things that, again, they'll feel in there, and that they have to be certain locations within the body, the hand, wrist, foot, and also that you see some X-ray changes like erosions, and that the serum is positive for rheumatoid factors. So you have different diseases, you have the same disease that using different criteria, someone may get diagnosed with the disease and they may not get diagnosed with the disease, depending on which criteria you follow. So in fact, they did this in a population in Sudbury, Mass, where they looked at if we use these different criteria in the same exact population, the results, as you can see, are quite different. So the New York criteria is a little stricter because you need to have those criteria, all of them met. So you see fewer people were actually diagnosed as having rheumatoid arthritis. Whereas the American Rheumatism Association, you can see that you have a much greater group. And in part, that is because of this serum positive for rheumatoid factor, which you don't need to have here, but you do need to have in the New York criteria where all 4 must be met. So again, different criteria that you use to diagnose can lead to different rates of disease in your population. And so this is critical too. If you're reading 2 papers, like you have your 2 papers, and you want to know whether drinking wine is related to an increased risk of rheumatoid arthritis. So you have 2 cohort studies, and one is using the New York criteria and one is using the American Rheumatism Association. How is that impacting the results? If one found a positive finding and the other didn't, would you say, well, maybe it's related to a different way in which they define the disease? So, you know, when you read a paper, there are so many different parts of it that you have to really think critically about. And this is just one more aspect. How did they define disease? And like when I was talking about spine fractures, and, you know, many people don't know they had them. So when we read papers in osteoporosis, sometimes they talk about symptomatic vertebral fractures. Well, very few of them are really going to come to medical attention. And the other way they do it is through X-ray evidence. And then the last thing is if you're really doing a study where you want to know for sure, you're going to get an X-ray on that person every year or at the beginning and end of the study. And depending on which way you did that, again, you will have totally different rates of vertebral fractures. So there was, as I said, there was a similar example in dementia, and this was a Canadian study. And when they used different criteria, so this was whether or not these, you know, almost 2,000 people had dementia. So they used these different classification systems. So the ICD-9, the ICD-10, the Canadian diagnosis codes, clinical consensus, and then these DSMs, which are diagnostic and statistical manuals of mental disorders. And these things are, you know, there's 4 different levels of this. So if I wanted to know what is, how many people in this Canadian population have dementia, I could get anything from 3.1% all the way up to 29.1%. So a huge difference in terms of how many people are said to have dementia. And if I was running the public health department in, say, this province in Canada, and I wanted to know how many people do I need to have in, say, nursing homes ready to take care of women and men with dementia, it would vary greatly depending on which criteria I use to diagnose these people. So it not only impacts the study you might read, but it impacts when you're trying to plan for what resources you need for the population, because you get a drastically different idea of who has the disease based on which of these criteria we use. So how are you going to get the cases or the disease people, the numerator for your number when you want to look at prevalence or incidence? So you could do interview data, and the issue is that a person may have the disease, but they might not have any symptoms yet. They might be asymptomatic, and so you're not going to get that person in your numerator. In another case, maybe someone has symptoms, but they never bothered going to the doctor. So when you ask them, do you have rheumatoid arthritis? Yes, they have, swelling and achiness in joints, and they might have a lot of the things in that criteria, but because they never went to the doctor, they're not going to tell you, I have rheumatoid arthritis. You can also use hospital data. The issue is that not all cases are going to get admitted to the hospital, and sometimes the records are incomplete. I'm working right now at the hospital I work at, and we're trying to get better in terms of our databases and our systems. And, sometimes the coder will put like 9 diagnosis codes on someone that was admitted, and other times there'll only be 3, or the doctor will only dictate 3 or 9. And yet, so the same person might have 9 diseases, but depending on what the doctor dictates, what the coder takes from that, it can vary a lot. So you're working with data that has so many levels before it gets to the final data set that can alter what is the real number of cases, that you really have to think about, why would there be issues, or why might this data be incomplete? And then there is also problems with the denominator. Sometimes we have undercounting of the population. This has been true for a lot of the census, where particularly minorities were being undercounted. Also, you have misclassification of ethnic groups. For the census, they let you self-declare, and whether or not the person is answering that honestly, accurately, is not really clear. So you might not have, if you're looking at a disease that's, say, prevalent in the Hispanic population, you might think you have a denominator, but there's all these issues that came into whether or not people are really classified correctly. And then also, you need to make sure that the denominator is truly at risk for the disease. And so we talked about prostate cancer, and you only use men. So we can say, okay, for uterine cancer, we have to base it only on females. But a lot of females end up with a hysterectomy. If their uterus is removed, they are not going to get uterine cancer. So how do you account for that? So they really shouldn't be in the population at risk because they don't have the organ that is at risk to get cancer. So these are, all of the issues that, you should think about. So here's an example going to the uterine cancer, where we're looking at the incidence rate of uterine cancer. And it's age adjusted, so they already took into account age. So it's not being influenced by age, this data. But what the rates are here is the uterine cancer here, uncorrected, is going to be all females. And if you include those women with a uterus, then you're going to get a lower rate than if you take them out of the denominator. You're going to have more cases, the same number of cases with a smaller denominator. So you're going to have slightly higher rates because you're correcting for those women without a uterus. So, if the county health department presented this and hadn't, really accounted for whether or not there was a hysterectomy, you could be off by a few percent. This is almost 6%, or 6 cases per 100,000 different at each time period. So make sure that you're talking about this population at risk whenever you do a incidence rate or a prevalence rate. You want to make sure you have your population there. So there is a relationship between incidence and prevalence, and this is in a steady state. And please think of this as a relational kind of thing. This is not a mathematical strict formula. It's how the two relate to each other. I'm giving you an example here where the math might work out right, but that's not the important thing. The important thing is when you think about prevalence, it's a combination of the incidence and the duration of the disease. So in a steady state, and there's no change in the rate or no change in the population, in this example, we screened 2 different towns, say for tuberculosis. So we screened Hightown and Lowtown. If we look at the prevalence of the disease, where is it higher? In Hightown or Lowtown? Right, Hightown is 100 compared to 60 in Lowtown. But now let's look at the incidence, and where is the risk actually higher in which town? Lowtown, and it's flipped. So why did it flip? It flipped because the duration is totally different. So whereas anyone that gets sick here is going to hang out and remain sick for 25 years, whereas these people are gone within 3 years. Why is that? Maybe there's a difference in medical care. Maybe there's a cure for one town and not the other. Maybe people are dying. There's different reasons, but what I want you to just understand is that in general, if you want to know the prevalence, you have to think about the incidence times the duration. So that's why 20 times 3 here equals 60, 4 times 25 equals 100. And like I said, don't think of this as a strict numerical equation. I gave it to you here just so you'd understand it. It's more important that you think about it, okay, what happens if the duration of the disease goes up and the incidence stays the same? What is going to happen to prevalence? Incidence of the disease stays the same, duration goes up. Prevalence is going to increase, right? If, on the other hand, I say the incidence is going down and the duration of the disease is staying the same, what's going to happen to prevalence? And that's how I want you to think about this. It's not, again, think of it like a math equation. Think of it that, if one goes up, what's going to happen to the other? That is how I want you to understand these numbers. Any questions? Okay, so you're at your desk, a reporter calls you, and they want to know if there's a change in the rate of extramarital births. So this is the graph you have. It's 1980, so go back in your time machine. But anyway, so this reporter says, is there a change in the rate of extramarital births? What would you say? How many say, yes, there is? Okay, we have 1. How many say no? How many don't care? It's a yes or no question, right? So, all right. Does it look like there is an increase in the rate of extramarital births? Yes? Okay, so what did you want to say? Right. And what did you want to say? Anything different? Okay, so let's go on to the next slide. So it looked like there was an increase. But what is really happening is, in fact, there's no change in this. If you look at the births to unmarried women, the rate, it's totally the same. What did I say this was? It was the percent of all live births. A percent is not a rate. So if the reporter said, I saw this graph, I think there's an increase in the rate, you'd have to say, no, that's not really a rate. It's the percent of births. This is actually the rate. So now when we look at the rate, we can see that there's really no increase in rate, but the decline in the total birth rate is making it look like a greater percent. Do you see how that happened? So remember, a proportion like what we showed here is not the same thing as a rate. A rate really has to take into account the time element. So here's the live births per 100,000 per thousand population. For each year, it's listed here. You can see the births to unmarried women, no change. But if this is dropping down, this percent is going to go up just because the denominator is going down. Okay, so this is breast cancer incidence and distribution of cases by age. So what you have here is, I want you to think that it's important to distinguish the distribution of the disease, the proportion of cases. So the age distribution is here. So what proportion of cases occur in those that are over the age of 80? So here's the axis for that. It's the percent of total cases. So over the age of 80, you have these two. So what is it going to be? Around what? Right, 8 or 9%, okay? So that's the percent of total cases that occur in women over the age of 80 is 8 or 9. This line here is the incidence rate. That's going up and up, right? And what happens to the risk as people age? Is it higher or lower? It's higher, right? Because the incidence and rate is your assessment of risk. So it's going higher. So here we have the highest risk, it's the highest rate up here, but say here in women over 80, it's only about 9%. So why is that going on? Pardon? Right, a lot of women die before they get to 80. So you're, only a few people are alive, so it's going to make a difference there. But if you live, your risk is going to be much higher than, say, someone who's 50 years old. So difference between incidence and a distribution or a proportion, percent of total cases. They are not the same, and you will get totally different answers depending on if you're looking at one versus the other. This is looking at the trends of incidence of thyroid cancer in children after Chernobyl. So they used surveillance to determine the impact of the accident at Chernobyl on childhood cancer. And what they found was the highest incidence in the most contaminated areas, which was this line up here, Gormel, and then also the Ukraine, which is this line here. So we can look at the trends of incidence over time to see, okay, well, when the accident happened, did we all of a sudden see a large increase in the rates? And yes, in fact, they did. So you can use this to try and look at trends over time as well, and it really helps to have it be incidence. This is incidence per million, so that you can know that you're comparing apples to apples. It doesn't matter if there was a baby boom in this year and it's really higher if you were looking at number of cases just because more people were born in that year. So always think about incidence versus proportion. Here's a measure of mortality. So it's the thousands of deaths over the years. This is specific to cancer deaths. So what is happening to the number of cancer deaths over time? It's increasing, right? Clearly, the number of cancer deaths is going up over time. Can we say that there's an increase in the risk of cancer over time? No. What's missing here? Right, the population at risk or the denominator. We need to have both. If, in fact, the population was increasing at the same rate over all of these years, there would be no increase in risk. So always think about what are people presenting to you, and does it make sense? Is it really looking at risk, or is it just giving us a proportion? This is looking at cancer death rates for males from 1930 to 2003. So this blue line here is lung and bronchial cancer. So you're starting in 1930 here and peaking all the way up here to about 1990, and we're seeing a drop now. Why is that? What's your estimate or best guess of what was going on there? Cigarettes, right? Cigarette smoking. So from the time of introduction, huge increase. Then with a lot of the campaigns to quit smoking, you start seeing a drop. That's like hopefully a benefit of public health, what we see here in terms of the drop. Stomach cancer, look at this. Stomach cancer is this pale blue line. See how it goes down like that? Does anyone have any idea why stomach cancer rates have dropped so drastically between 1930 to here? Yes?
Antibiotics for H. pylori.
Exactly. It's H. pylori, and H. pylori is a huge risk factor for gastric cancer. As soon as we took care of a risk factor for the disease, we saw a huge drop in the rates. And, hopefully we'll see something similar, say, with the vaccine for, what am I thinking of? Cervical cancer, the HPV vaccine. Maybe we'll see something similar to what we saw with the stomach cancer rates and the treatment of H. pylori. Any questions? So this is the cancer death rates for females, again using the time period that we just saw, 1930 to 2003. So let's look at breast cancer. That's the pink line here. Not really a huge change, right? It doesn't look like a lot is going on. So there seems to be no change in breast cancer mortality. Do you think that treatment is ineffective? Yes?
I'm not sure, but don't people, it delays mortality, but eventually death?
Right, so it might be that we actually have a decrease in the risk of death. So if you think about that flask and the incident cases coming in, there are going to be more people there, but it's also an increase in the incidence. If you have more cases, and maybe that's in part because of mammograms and things like that and a better detection. So it could be a decrease in the risk of death. It could also be an increase of incidence. We don't really know, and we shouldn't start going to the doctors and saying, you're doing nothing to breast cancer, because look at the mortality rates are the same over time. So any questions? Okay, so we can talk about, as the slide just showed, mortality rates. Typically, we're going to talk about mortality rates per 100,000. Usually, it's annual. It could be 5-year. It could be any amount of time you want. It's the total number of deaths in a year divided by the number in the population at the mid-year times 100,000. So remember that because you're looking at this over a whole course of the year, you don't want to use the population just at the beginning or just at the end of the year, and we try to use the midpoint for anything where we're talking about a full year of either mortality or incidence. Use the midpoint average population. And you can specify these mortality rates for ages. You can do it for causes of death. We just saw it for cancer deaths. We could do it for myocardial infarction. We could do it for a lot of different diseases. So here's an example of a mortality rate calculation. So, and this is what we call accrued death rate. We're just giving the absolute numbers. We're not controlling for whether there's an older population or a younger population, which can make comparisons difficult. But it's the number of deaths in a given year divided by the reference population during the midpoint of the year times 100,000. So if the number of deaths in the United States in 2013 was about 2.5 million, and the population in the US in July of 2013 was about 290 million, you end up with accrued death rate of 841.9 per 100,000 in the year 2013. So does everyone see how those numbers are used? So death rate or mortality rate is one thing that we use, and it is important, and it's usually pretty good because as long as the cause of death is defined accurately. But you can imagine if there's not care taken with that, then the mortality rates are also not as good as they could be. But sometimes we care also about the severity of the disease. And in that case, we use something that's different than the mortality rate, and that's called the case fatality rate. And this is the number of individuals that are dying during a time period after the disease onset or the diagnosis divided by the number of individuals with the disease. So it's not the population that's the denominator. Here it's out of all the people with the disease, what percent end up dying from it? So what percent of people diagnosed with a certain disease die within a certain time after diagnosis? This is important because we think about if it's got a high case fatality rate that we better act and act quickly, or else there's going to be a lot of people dying from this disease. So if you have in 100,000 people, we get 20 people with the disease. But in 1 year, 18 die from that disease. The mortality rate is only 0.018%. We're not, it doesn't seem like a whole lot compared to some of the rates that we might see, say, for cancer or some of the other diseases. The disease is rare. But we are very concerned with this disease because it's got an abnormally high case fatality rate. Out of 20 people who got the disease, 18 of them died within a year. So the case fatality rate is 90%. So that helps us to understand how severe a disease is, and that might be something that we want to put more people on to try and figure out what's going on, because the outcome is so severe when you get the disease. And so in that case, prevention and things becomes key, because if you can prevent someone from getting the disease, you might prevent a death from that disease. You had a question? It's not as important. Whenever you have a proportion, you don't need that concept of time that much, but it makes more sense, because if I give a case fatality rate of 18, it's usually 1 year or 5 years. It's not like in a lifetime, because then it means something different, because you don't even know if they're dying from the disease. The further out you let that time be, the less sure you are that it's related to the disease they were diagnosed with. So usually it is a short period of time that you'll do a case fatality rate for. Anything else? Okay. So proportionate mortality from cardiovascular disease is the number of deaths from cardiovascular disease in 1999 divided by the total US deaths in 1999. And this tells us the major causes of death, not the rate. So remember on the last week in the first class, I talked about, what are the major causes of death? What are people dying from? And you really need the mortality rate to tell us the risk of dying from disease. So this proportionate mortality, again, helps us in planning health services, resources that we might need for prevention. It gives us an idea of all of that. And it's the cardiovascular disease divided by all deaths. So in different ages, you can see that there's a different proportionate mortality. And just like you would expect with cardiovascular disease, it starts going up in, about the 40s, and then as people get older, it's something that's going to end up killing about half the people. So the proportionate mortality rate is something that will clearly change with age. And when, if any of you take the policy class next semester, some of the things we talk about is this is for the United States. If we looked at this, say, for India or some other countries, the proportionate mortality rate for cardiovascular disease in younger men and women is much higher than it is in the United States. People are getting these chronic diseases much earlier and dying from them much earlier. So there are also problems with mortality data. We talked a little bit about the incidence data and prevalence, and how we detect the cases might impact the accuracy of it. In terms of mortality data, death certificates are the major source of data. When someone dies, you get a code that's indicating what is the underlying cause of death, and that's what we base our studies on. Sometimes in different countries or in different regions within the country, it might vary in terms of how accurate this record is. How seriously do they take this in terms of understanding its importance later in trying to understand risk for death from certain diseases. There's also issues that when the ICD codes change, that then it's hard to compare 1 year to the next. So right now we're doing ICD-9. We're supposed to change to 10 by next January. And so, with that change, it's going to be important to understand what has changed. What do we used to call like a 800.1 in terms of an ICD-9? Is that still the same thing in 2014 with ICD-10? And knowing how things are classified and how they change helps us to understand what kind of an impact it could be on us understanding changes in mortality. Are they real, or is it really something due to coding? There's also limitations of the mortality data. In terms of certification of the cause of death. So for example, if you have an elderly person, they have chronic disease, usually multiple chronic diseases. They might have breast cancer, heart disease, osteoporosis, and a stroke. So how do you know what was the cause of death? What are we listing as the primary cause of death? And there's some lack of standardization of saying, if it's this, it should be coded as that. So it's kind of a judgment call in terms of the doctor who's filling it out. The other issue is that with certain diseases, for example, in AIDS, there was a stigma associated with saying someone died from that, so sometimes the death certificate would list something else, particularly in other countries. So there are limitations and things that we have to understand when we're using mortality rate data, and it doesn't mean we can't use it, but I tell you these things so you understand what are some of the subtle issues that there might be, and these are the kind of points that would go in a discussion. Yes?
If a person dies from, let's say, bad interaction with a medication that causes a heart attack, would that be listed as a drug overdose or heart condition?
So usually it would be a heart condition, and then they would have an underlying cause as being a medication. And you can get specific to that kind of codes when you're looking at the mortality data. Like, so you'll have a primary cause of death, which might be the heart attack, but then they'll have underlying causes or other conditions, and they're listed as well. So that also makes a difference in terms of when if you're the one on the end of analyzing all this data, what are you really looking for? And that's the kind of thing we're dealing with in our hospital, not as much with mortality, but people come to our hospital and then sometimes we're a rehabilitation facility. Sometimes they have to be sent back to acute care. Well, why did they go there? What was the primary reason? And was it related to something on admission? Because it all comes down to cost, and in the future we're not going to get paid for those people that leave for, acute care. So we have to understand, and we have to understand what's put in the codes when they come in. What do we code when they leave, and do we put everything there so that we can really get at the answers? So it's becoming, we're towards electronic medical records, and that's a great thing, but there's a lot of subtle things that haven't really been thought out, worked out, and we still have a ways to go. So although I'm telling you that's how it should be done, it could be something totally different. If a family is there and, they're like pleading with the doctor, we don't want anyone to know this had anything to do with drugs, he might leave it off. So it's not an exact science, and that's a problem. Yes?
Are there methods of monitoring whether the doctor is covering up for the patient's family? Is there some kind of
There's not, so what you have is usually a doctor might fill out the cause of death at the time, and then if there's an autopsy, certain number of cases will go on for an autopsy, and then that could contradict it, and then there would be an issue. And there's set rules about, I don't know what they are, but if a person dies at home and they're younger, they're almost always going to go for an autopsy unless they knew that they had, metastatic disease and, might die. So certain people will end up with an autopsy, and in that case, then they can't really hide it, and they just would have to tell the family. Anything else? Okay. Sometimes we'll see a trend in mortality, and it might be an artifact. It might not be real. And these are the kind of things that I want you to be, critical reader and think, well, is this real, or is there a reason maybe why I'm seeing some trend that isn't real? So it could be an error in the diagnosis or in the coding of the diagnosis. It could be an error in the person's age. What age are they listed as? Are they really 90 years old, or are they actually 50? It could be a change in the coding rules. I talked about ICD-9 versus ICD-10. Changes in classification besides the ICD-9 and 10. There's other classifications that we use. It's also in terms of the denominator. Remember, when you're talking about trends in mortality rate, you have your numerator and you have your denominator. And we talked a little bit about some of these errors in counting the population, errors in demographic classifications, particularly those people that are, of different ethnic backgrounds are not always counted as accurately, and also differences in the population at risk. Have we really accounted for that, someone maybe is not at risk for the disease, say it's uterine cancer because they had a hysterectomy in the past? So there's a lot of things that would come into play, and one example that I want to give you here is if you look at AIDS cases by year of report in the United States, this is from 1984 to 2000, you can see that there was this huge peak here. Well, was there really a spike in the number of AIDS cases that occurred in 1992? Well, in fact, it was a new definition that was given for AIDS. And as soon as that new definition came out, then many more people were classified with having AIDS. So they kind of expanded what they were calling AIDS in terms of when they were doing surveillance out in the doctor's office. So that accounts for this initial peak here. But the reality is, it still seems to remain fairly high for a while. And usually if you have a change in the definition, it'll kind of go up and then drop back down. So there probably was a slight increase in a real increase in the rates as well, because otherwise this would not have stayed up for so long as it did. So there are also explanations. Maybe there's really a change in mortality, but we can help explain it. There could be changes in survivorship, or how many people with the disease end up dying without changes in the incidence. It could be that there's a change in the incidence. More people are getting the disease, and that's why the mortality is going up, because you have more people with the disease. It could be a change in the age composition of the populations. Like sometimes for cancer, people will be concerned that they live near an environmental hazard, and so they want the health department to come and evaluate, is maybe this increase in cancer I feel is in my neighborhood related to this buried waste or whatever. So they might do something like that, and there's careful things that people have to do, because if it turns out that they're comparing it to rates that we're seeing 10 years ago, a lot of times neighborhoods go through this transition where all the kids, grow up, they leave the house, and so those people move out, and then younger people move in. And you need to consider, say, the age composition of the population changed, and that's why we're seeing a change in the rates. So there's a lot of different things that can happen, and there can be a whole combination of these factors. So there could be a change in the age composition because of what I just said, but there could actually be more cases of cancer occurring there. And you really have to just work through it all and try and figure out what is the best estimate about what's really going on. So we've talked a little bit about mortality. We've talked about incidence and prevalence, which is getting at the disease rates. And I just want to talk about that kind of other period, which is the when a disease impacts someone, but they're not dying from it. And that's a thing that is oftentimes measured as years of potential life lost. So I really just want to get you to understand that that concept exists. So it's the years of potential life lost before age 65. And this is for all races, and males and females, and for everyone in the United States in 2004. And so the causes of death that are likely to take more years of living away include what? What is one of the most common causes that takes years of living away? So it would be this one here, right? Unintentional injury is almost, 20% there. Suicide you can look at is about 6%. So there is injury and suicide, and then there's also the things that we think about as really taking people away earlier, including cancer, heart disease, and then deaths that occur during childbirth. So just to know that, there are other ways of looking at either disability or years lost or other things besides getting the disease and going all the way to mortality. There's other measures you can make in between. For the grant I just put in where we're looking at pelvic fracture healing, we're not looking at mortality as an endpoint. We're trying to see, can people do more activities sooner with the treatment we give versus the placebo? Can they get up and walk sooner? Can they, do a sit to stand in a faster speed? So there's different things that you can measure in between the spectrum of getting the disease and then dying from it. So this is something, again, that relates somewhat to the slide I showed you during the first time, but this is for developing countries. So remember we talked about communicable diseases in the United States back in the 1900s was the major cause of death. Now we're to non-communicable diseases. Well, what's happening in developing countries is that in 1990, about 42% of the deaths were related to communicable disease. Now, if you look at that same number, it's dropped down to about 17.5%. So there's been a huge transition in terms of what you need to do to prepare to have more of these people survive 2020. Sorry, this is 1990, and this is predicted in 2020. So whereas before we were very concerned with people that coming in, children, and making sure they have enough nutrition and making sure women had safe childbirth, and not thinking that much about diabetes prevention and obesity and all of that. Now our minds have to start thinking, how are we going to deal with this? And if you look at a lot of the seminars that are going on throughout Columbia University, this is coming into play now. So they're really starting to think, how are we going to deal with chronic disease in the developing countries? What is there? In the United States, we have this great resources. We have the CDC, we have Department of Health that's for states and then specifically for counties. We have a great kind of grid set up. These don't exist in some of the developing countries. So how are we going to handle the disease transition there? Just to go through a quick problem, during 2008 in Finland, 269 boys died at the age less than 1 year. The size of the male age group was 33,200 in December of 2007, and on December of 2008, it was 32,500. The number of boys born alive during 2008 was 32,800. So what is the mortality rate in this age group of boys? So what would be the numerator? I don't need you to give me a strict number, just what would be the numerator? $269, right? That's how many boys died, 269. What do we divide by? Right, the mid-year or the average of the two. You have two endpoints there, so you can look at that. The mortality rate would be the mid-year population. So we have in 2007, it was 32.2, 2008, 32.5, so you can take the average of that. And that would be your denominator. Does everyone understand that? That's the midpoint. I probably should have put here mortality rate in 2008 in this age group of boys. We can also look at something called the infant mortality rate. And this is the number of deaths in those less than a year during a calendar year divided by the number of live born children during the year. So what would this measure be for this population? What's your numerator? It's still 269, but now what are we dividing by? Right, 32,800, the number of live births during that period. Does everyone see where each of those numbers came from? Okay, so this infant mortality is a common measure that's used in public health internationally, and this is the way that some of these graphs will show it. So this is looking at infant deaths per 1,000 live births throughout the world, and what you can see is this is 0 to 4, the green and blue is 5 to 9, so that's pretty much in North America what we're seeing. But in some of these areas, like in Africa and Asia, we're seeing rates that exceed 130 per 1,000 live births. And so this gives you an idea of the infant mortality rate, and then you can kind of think, okay, what kind of resources do we need to send to which countries to help prevent these deaths from occurring. And then, so this is an international look at it, and we can also look at it in terms of nationally, and this is showing the infant mortality rates in the United States by race and Hispanic origin of the mother, 2000 to 2002. So this top bar is white, not Hispanic. This is black, not Hispanic. This is all Hispanics, and then breaking it into Puerto Rican, other Hispanic, Mexican, Central South America, Cuban. And then they also go into Asian or Pacific Islander, with it broken down to Hawaiian, Filipino, other Japanese, Chinese, and then American Indian or Alaska Native. And so you can see that within various subpopulations, even within the United States, we can see a difference in something as basic as the infant mortality rate. So any questions on this? So what we're going to do now is take a 10-minute break. So if you can come back about 4:35, and then we'll go through the second half of the lecture. Hi. Okay. Proportion. Right. No, because it still is, the think about it, it's not like an active number doing that. It's not, it's just a proportion. They're using the denominator, like it's the percent. So it's like a fluid number, but it's not a rate. Because what is the concept of time? Yes, it's given per year, but that's not really enough to call it. Right. Right. Yeah, that we haven't really talked about. So, like, I could ask you, what is the cumulative prevalence of having, or lifetime prevalence of having something that comes and goes? Not at all. So, like, say tuberculosis. So it might be that, you know, you had it when you were 18, I had it when I was 50, but we both were counted as a case, even though we heard it different times. Maybe might have heard 10 years ago you had to sleep in a year. So it's just like, have you ever had this in your lifetime? So in most studies, if you're doing, say, a cohort study, you start out with a really clear disease. Once the person gets the disease, they drop from that list. So you don't keep on counting them forward.
And then some of them will like everyone's like each team is $10.
Oh, okay. If it's so, you know, one of the things that, you know, relates to was something like fracture, and we handle it different times. So sometimes we'll say time to the first fracture, or we'll say people with multiple fractures, which got, you know, a lot during the follow-up. So it's how you define what you're looking at, and we can get. So it's just really being clear about what you're looking at. So in a case of something like a fracture, where yeah, we think things are going to break again, that same bone or a different bone, there's also, you know, how do you count that? And so people will say time to first fracture. Or they'll say, you know, say that like what fracture each one is a case. So they have to tell you if they're not going to do that.
Get out of the way, show off last.
The extramarital birth? Okay.
That's what I mean. It's the time step. Okay. I don't know if I should take this one out. Okay.
Hi.
Just remember, we're always using the midpoint of the population. We're talking about the population changed over time. Let's take the midpoint. Or the average. You didn't know I talked about it. That's for 2008, but see, these things happened all throughout 2008. So if it happened earlier, it might have been 32,008. If it happened later, your denominator is 32,800. Since you don't know when each one does occur, you just average the two and say the average of that. No. Because you're doing it for 1 year. You're doing the mortality rate for that 1 year, 2008. So it's December 31st, 2007 to December 31st, 2008. Okay. Hi.
Hi. I was still having a question about the odds ratio and the p-value, just when I was reading the article. Can you
Okay.
please explain to me the odd ratio again?
Well, I'm going to
Odds
explain it when we read the
Okay.
papers, so come to me after class if it still
Okay,
doesn't make
great.
sense, but that's part of what I'm going to
Great.
go through.
And thanks. And also, if I have questions or want to come in, you're busy, but the TA of this class, I could.
Yeah, I mean, I'm here for the hour before class. I'm
Okay, you
at
are.
IHN.
Oh, the problem is I have a class right before.
Okay, so then call Monique or email her and say,
Okay.
could we meet?
Great.
And
Thanks.
she's good. She'll be able to help you.
Thanks.
Bye. So this was the size of the bill each one of us wanted 32,200. Right, so that's really the beginning of 2008. At the end, it was 32,500. So, or something like the mortality rate only requires the duration. So then for this one, we just said that the infant mortality rate is the number of deaths less than 1 divided by number of live born infants. So we told you the number of newborn alive was 32. How many newborn born died? I don't know. They're two different numbers. Some of them died. Well, we started with 32,200.
Like, I would have to really.
Some of them were like 9 months.
Sorry, can you just this way?
So they're going to come out of the higher, the denominator. And that's why you need to use the average, because you don't know what age they were and how long they would be in there. So if you use the average, you get a better estimate. Because again, these numbers are based on everyone that was under the age of 1 at December 31st. So these are going to be not just the ones that were born during that year. It's going to be people that were born from January the year before all the way up till December. So some of them are only a day old, and some of them are, it's what we talked about before, they're aging out of that. Yeah, because your denominator is just under 1, so that's why they age out. It's really, they got old enough to.
I have a quick question. So between prevalence point and prevalence period, I just got a little confused because at one point you're okay. I got point is just like right now how many people have this, right? But then point turned into a month, and so then I started thinking, well, what's point like right now or then a month?
Right, I know. It's a little bit confusing, but
Yeah.
usually, like your period, for most things, if you're dealing with it, you're going to talk about a year.
Okay.
For, say, the period prevalence.
Okay.
Only would you talk about a month period prevalence if you were, say, doing flu and you were doing it month by month or something that,
Okay.
changes so drastically by
Okay, I
month.
see. So it really depends on the context of whatever the
Right,
study is.
right.
And then within the study, you usually see them compared, so that way, is it
And
more
like when I
distinguished?
say like in that month, it's really not within that month. It's like on January 1st, I came in and asked the class how
okay.
many. So my
Oh.
measurement for January was that.
Oh, I
But it
see.
wasn't everything that occurred in January. It was just on this date in January. This is
Okay.
how many I got.
That makes more sense.
Okay?
Thank you.
You're welcome. If you guys could take your seats, we can try and get started. So we're going to change gears and talk about ecologic and cross-sectional studies. So we talked a little bit about the measures that we make, and now we're going to go on to two different study designs. So one of the frequent uses of epidemiology is to try and see if a risk factor leads to an increase or a decrease in disease. So we might want to know, does an increase in nutrient X decrease the risk of disease Y? Or does nutrient X deficiency lead to more of disease Y? Or perhaps an excess of nutrient X leads to more disease Y, like you're reading for today. So when we're talking about trans fats, does it lead to more adenomas? In general, we're hoping with most nutritional things that we're going to be reducing disease as long as it's healthy components of the diet. So these are the kind of questions that we might want to answer, and during the next several weeks we're going to go through different study designs that we can use to try and get at these questions. So just as an overall, going from today forward in time, we talked about last year how sometimes clinical observations say the surgeon that noted a lot of lung cancer cases happened to have been smokers in the past, can lead to looking at maybe available data. What's the surveillance data? What can I see in my hospital? And some of the available data is what we're going to talk about today, cross-sectional and ecologic studies. Then there's some where you say, I have an idea this nutrient might, reduce the risk of this disease, so I'm going to plan a study. And then you would do either a case control study, a cohort study, or a randomized clinical trial. And each of these we're going to do within the next 3 weeks. And as you go from the top here to the bottom, you're going towards the gold standard. So the best study design that we have, or where we really feel the answer we get is the most pure, is going to be the randomized controlled trial. So we can categorize epidemiologic studies, which, remember, when you do give me your 2 papers for your paper for this course, they all have to be epidemiologic studies. They can be based on their design, so it might be that they're cohort or longitudinal, prospective. You'll hear all of these words in the readings that you do. It could be a case control study. It could be a cross-sectional study. You can also talk about epidemiologic studies based on the unit of analysis. Almost all of the studies we do are based on the individual level. We have a person, they have the disease or not, we ask them about their diet. But sometimes we're talking about more a group level, and that is going to be ecologic studies. And we're going to go through this in a little more detail now. So how are the outcome and the exposure measured? So if your outcome is a nutrient, your exposure is your outcome is a disease, your exposure is a nutrient. How are you measuring these things, and how are you analyzing it? So if you're asking individuals, what did you eat, and do you have this disease or not, or you already know they have the disease or not, that unit of analysis is going to be each one of you as an individual person. If instead we're talking about an ecologic study, the unit of analysis is usually going to be groups or populations. And these can vary in their size. So when we do ecologic studies, it could be as small as a county within New York State. It could be larger, like a state or a region, the Northeast. It could be the size of a neighborhood. It could be based on hospitals. But in this case, when you do an ecologic study, the exposure and the outcome are measured for each group or aggregate, not for the individuals within that county, but for each county. And then we basically use correlation analysis to look at the exposure rates and disease rates and see whether or not they are related. So some of this is going to become a little more clear as we go through some of the examples. So there could be an ecologic comparison study that examines exposure rates and disease rates among different groups over the same time period. Or it could be an ecologic trend study that's looking at exposures that might change and changes in the disease within the same community, county, or other group. So for example, we could be looking at whether as the consumption of meat increases based on cattle data, how many cattle are sold and how much meat is imported, and how it relates to cancer rates. And so that could be examining exposure rates and disease rates among different groups over the same time period, because we could get that for different countries and see if the rate of cancer changes as the meat consumption changes. Or we could look within the United States and say we've had a drop in the intake of red meat. So let's look over time. If we look from 1970 to 2013, what has happened within the United States? As the meat consumption goes down, have cancer rates gone down? So those are the two different ways that you could do it. So the statistical analysis is typically a correlation. And for those of you that aren't as sure what a correlation is, it's just describing the linear relationship between two variables. And that's measured by an R value. So if you think about a correlation, you're just going to have a relationship here. So say this is meat, and this is cancer. And then you'll have all these dots. And you'll kind of get an idea, does it look like there's a relationship that we could draw through like that? So that's the idea of a correlational or a correlation analysis. So the R value can have a value between -1 and +1. This is +1, but if instead I switched the meat to be something like fruits and vegetables, maybe then we'd see the line go the other way or have a negative correlation. And what you end up being able to say is for every change in meat consumption of 1 gram, we see a change in cancer rates of 10%. So when I'm talking about this graph here, each of these dots is not a person, it's a country. So say it's the United States, it's Switzerland, each one of the dots is a group of data. Or it could be within the United States, each of the dots is a state. So these are groups when we're talking about ecologic studies. And this correlation coefficient just kind of talks about how strong is the association between a possible risk factor and the outcome that's measured continuously. So we use the R squared to talk about the proportion of the variation in the outcome explained by the variable. So let me just give you an example that's shown here. So if we were looking at the correlation here between dietary calcium intake, so let's change the meat here, and we're going to put diet calcium, and we're getting this from some international records. And then here we're using blood pressure, increased blood pressure. And here we're hoping that the relationship goes the other way. So as you have more calcium intake, you're going to have lower rates of elevated high blood pressure. So if the correlation there between calcium and systolic blood pressure was 0.4, we would say the amount of variability it explains is R squared, or 16%. So I'm not going to have this on your midterm or anything. I just want you to be able to understand when you read the studies what some of the basic, and as I go through some of the next slides. Yes?
With these correlations, what is a typical good correlation for epidemiological studies? Because I know when I did research like in chemistry, you wanted it to be like 0.99.
I'd love that.
But if you do it in something like a sociology or an anthropology, you're lucky if it's like a 0.2 or something.
We're about the range of the anthropology. So a good correlation is sometimes going to be somewhere around 0.2, 0.3. You know, we're not getting much better than that. In a study of individuals, when you do something like this, your correlations tend to be a little bit higher, and you'll see with the examples I give. But in general, like say my dissertation, I was looking at dietary intake versus bone mineral density in women. And I was really happy when my correlations were like 0.25, 0.23, 0.2, 0.19. You know, I was happy. And they turned out to be significant. So you're not talking about strong correlations, because when you think about what we're studying, say if we're looking at diet and disease, first of all, I was looking at, say, only calcium and bone density. But there's also magnesium, potassium, all the other nutrients. There's also whether they exercise. There's also, you know, there's a lot of other variables that come into play, and you control for them as best as possible, but it still is a cause of disease, a multifactorial cause of disease. So here's an example of an ecologic study. And so this is what I mean by sometimes the rates will look much better in an ecologic study. So this is looking at 23 different countries. So each of the countries is named here. So you can see the United States is here. You can see Japan is all the way down here. And it's looking at what is the daily meat consumption, and then what is the colon cancer incidence in females on this axis. And you can see that there's a pretty strong relationship here. The relationship, again, here is between per capita meat consumption. So it's based on how much meat was consumed in that country. We don't know what that means. You know, yes, it was consumed, but was the female eating it, or in that culture, do only males eat the meat? You know, it's hard to know what it means, and that's some of the issues with these studies. We're doing the best we can with very limited data. But sometimes it's very useful. And in fact, there's Keyes has a calculation to try and figure out cardiac disease. And this is some of his early work that was looking at 10-year coronary deaths per 10,000 men as compared to the percent of diet calories from saturated fats. And so this, again, is looking at, in the whole country, in this whole region level, what was the association? So here the correlation is 0.84, so that's really high. But each one of these is a different region. It's not like it's Mrs. Smith or Mr. Smith and this is Mr. Jones. Each one of these is a region, and we're getting an estimate for that country, what percent of their calories come from saturated fats versus what is their coronary heart disease death rates. So it's more crude data, but you see pretty strong correlations. So here's another one where we're looking at here dietary fat intake and breast cancer by country. So before we looked at colon cancer, now we're looking at breast cancer, and we're looking at dietary fat as compared to meat consumption. But you see that the countries kind of line up like they did before. Here's Japan all the way down here. Here's the United States all the way up here. But again, look at what the axis is. We know pretty well what is the incidence rate per country in terms of breast cancer, but the per capita supply of fat calories is an estimate, and it's made based on, you know, what is the average intake of people in the United States, what proportion of that. So it's using like gross estimates of what the intake is for the whole country and applying that to make this one little circle here. So perhaps you could take NHANES data and say on average in the United States we eat, you know, 20, what is this, about somewhere around 1,400 fat calories or whatever on average. But that's not what an individual does. It's just, you know, and some of that fat that is consumed might really not be consumed by this woman who has the breast cancer. And these are the issues with the correlation analysis. Yes? Right. So what she says is one of the other things could be how common are mammograms in that country, and that might impact what are the rates. So that's great. That's one example, and we're going to go through a few more slides and then talk about what are the other examples of what could be different for each one of these dots. So here is looking at salt sold in counties of Henan province in China and esophageal cancer. So here you see salt sold, kilograms per person per year, and the age standardized death rate per 100,000. And here is each of these for each of the counties within this province within China. So you can see that there's, a slightly positive correlation where the more salt that's sold, it seems like you have, on average, higher esophageal cancer rates within those counties. Again, group level data. So there's some issues that come into play. So when we're talking about ecologic studies, for each country, we might know that the prevalence of coronary heart disease is 5, 3, or 1%. Like here is 5% coronary heart disease in country 1, 3% in country 2, and 1% in country 3. And we might know the fat intake in terms of, is it a high fat intake or not. But what we don't know is within each of these cells, are the people that have the coronary heart disease, the people that say yes to coronary heart disease, actually the ones that have the high-fat diet? We have no clue. We just know that on average that country has a higher fat diet, and on average they have higher rates of coronary heart disease. So there's no information on what we call the cross-classification of exposures and outcomes within these groups. We know the outside of this fourfold table, and we're going to see a lot of fourfold tables this year. So we know these outside things, but we have no idea what the middle part is. And this is just looking at this for the high-fat diet and the coronary heart disease graph that we had seen before. So it's a very important concept. So, just putting this another way, is that the limitation of the ecologic study is you cannot be sure that the people who got coronary heart disease were the ones who had the high fat diets. And that's what the issue is. We have each of these things here. They're dealing with countries, but we have no idea whether the individuals with the disease are the individuals with the high fat diet. Because each country is not necessarily, just one rate across the board. Everyone eats that percent of fat diets. So that's where the issue comes into play. So to give another example, another limitation is that we have no information on individual variables which may be confounders, something like you talked about mammography. But what about the caloric intake? Is it different? Caloric intake is related to breast cancer. So how do we know that the caloric intake isn't also high here? And that's not what the real cause is. It has nothing to do with the fat per capita. How do we know what the exercise rates are? Exercise tends to protect against breast cancer. We have no idea what the individual level or the country level of exercise is when we're doing these kind of studies. And these are what some of the issues are. It's a good way to get a quick and dirty look at something, but it is not going to give you the answers. So in general, with ecologic studies, the group level variable, what we find for country by country, may not be the same thing as the individual level example. So, just because they have high fat in there doesn't mean it's the individual with the high fat with the coronary heart disease. So what if the study looked at per capita grain consumption versus colon cancer? So they could do that, and they've done some studies like that. But the problem is the grain is measured as per capita grain consumption, but the per capita also includes what's used for animal feed and everything else. We don't know whether the people even, not only is it the specific person eating it that got the disease, but are the people eating it at all, or is it being used as animal feed? And is that varying by country to country? So these can all come into play and cause issues in doing these kind of studies. And one of the other issues is that we're using secondary data sources for the disease. We're not going out and doing our own study. We're not having the same strict controls on the study as we would otherwise. And so that can be an issue. So the quality control isn't always that great. We only have whatever information we have. Maybe physical activity rates vary country by country, but we don't know that. We also don't know if there's temporal differences. Are there differences over time in terms of how the diet has changed or how the cancer rates have changed? And how accurate things are reported to, countrywide registries may not be that accurate, and that could make comparisons difficult as well. So just as another example, here is something looking at the annual consumption of beer and the age-adjusted incidence of rectal cancer per 100,000. So we don't know, is this males or females who's consuming the beer? Is it the person who has the rectal cancer? We have no idea. So these are issues that come into play and make it difficult to interpret this. And this is all globally given into a definition called the ecologic fallacy. And what this says in a nutshell is that if you make observations at the group level, so country by country, it may not represent the exposure and disease relationship at the individual level. And so you have to be very careful if you're reading or talking about an ecologic study that you don't try and say that this applies to data at the individual level. That would be an ecologic fallacy. So you don't want to look at this data of salt consumption and esophageal cancer and say those individuals with higher salt intake had greater rates of esophageal cancer, because you have no idea what happened at the individual level. So don't over-interpret the data from an ecologic study. It's those nations with higher, or those counties in this province in China with higher salt intake had higher esophageal cancer. Do not talk about it at the individual level, and especially not as in terms of risk. So in reality, sometimes the conclusions obtained from an ecologic study may be the reverse of those from a study that collects data on individual subjects. And I'm just going to go through an example to help you to see this. And it's very important to make sure that you don't ever overinterpret these data from an ecologic study. So here's an example. So we had a study, and although we're looking at 10 individuals, it's just an example, so we're not talking about individual level data, who go into the sun. And they found that 7 people, or 70%, had sunburned foreheads, although 6 people, or 60%, wore hats. So the expected number of sunburned foreheads is 4. How many people didn't wear hats? There were 4 people without hats, so we would expect it would be about 4. So the media reports that wearing hats will not protect you from sunburn. So let's go on and see whether that actually makes sense. So this is just looking at things in a global way. So instead of talking about 10 individuals, think of this as 10 countries. Each person is a country. So this is what the individual data show. So what you can see is person 1 wore a hat and they had a sunburned head. So these first few people wore hats, but they had the sunburned head. The 4th person didn't wear a hat, they had a sunburned head, and on it goes. So this is looking at each person as an individual that either got a sunburn and wore a hat, and looking at the individual data to try and see what it shows. So if we summarize all of this that's laid out here, we observed that 100% of people who did not wear hats were sunburned. So let's go back to this. So the no hat wearers, yes sunburned, yes sunburned, yes sunburned, and yes sunburned. So every person without a hat did in fact get sunburned. And among people who wore hats, 6, only 50% were sunburned. So in fact, when we looked at the data as just looking at group level data, it looked like the hats didn't make a difference. However, when we look at they say that wearing hats won't protect you from sunburn. But when we looked at the individual data, we got the total opposite conclusion. Because now, looking at the individual level, if you wear a hat, it affords protection from sunburn. It reverses that original conclusion. So in fact, hats are protective, but you need to look at the person-by-person data. Everyone clear on that? So the strengths of these studies is that some exposures may vary little or not at all within a given group. So if I wanted to look at dietary calcium intake versus blood pressure, what if in the United States everyone was just down here? No one had more than 600 milligrams of calcium intake. It would be hard for me to do a study. By doing it country to country, we kind of widen that exposure window to look at very low intakes to very high intakes. So it allows us, by doing an ecologic study, to really expand the range of exposures we can look at. So another example, I gave you the calcium. If diet varies little within countries, for example, dietary fat, maybe we only have a range of 15 to 40% here, it may not appear to be an important risk factor for coronary heart disease. And only by comparing countries with very low intakes to very high can we actually see this relationship. But again, the problem is we don't know if we could control for all this individual data, would it show anything? So, the way in which this works well is kind of pointing us towards hypotheses that we can then go on to test. And Dahl and Pito were two doctors that first looked at diet and cancer back in, I think, the late 70s to early 80s. And they came up with this little red book looking at this. And a lot of it was based on ecologic studies. But it got enough to get people saying, diet may be related to cancer. Let's go out there and do more studies. And so they are important for spurring people on to look at the effects of whatever were studied in the ecologic studies. So there are certain variables that can only, that are only defined and can be only measured for groups, and the only way to study these is at the group level. So something like water fluoridation, where I showed you during the first class and talking about whether or not it reduced the amount of decayed, missing, and filled teeth. Healthcare policies by country, before Obamacare, it was always, well, what if we had different kinds of health insurance here? Would we do better in terms of mortality rates for certain diseases, or would it be worse? And that's the only way you can really look at this, is where there are these kind of changes. But some of the advantages are that it's very low cost. It's very easy to do. You just get public records. You can get them online now. You can put together your own little ecologic study very easily. You're using all data that was already collected by someone else. And sometimes there is no individual level data. So doing these kind of studies is the best you can do. And again, importantly, you might generate some hypotheses that later on we can go on and test in the cohort or case control studies. So they can be important for a number of reasons. The disadvantages are that we can't draw inferences on an individual level association. What's that called? Right, ecologic fallacy. And the fine points of a particular relationship may be missed because maybe you don't know that it's actually exercise. I'm sorry, that's the next one. It's hard to control for confounding variables. Maybe it's really an effect of exercise, and we're not seeing that. And also, we don't know what the quality of the data collection was. And so we have to kind of explain that in our discussion, that we used what was available, but it might not be the best data available. So what is the difference between individual and population-based studies? So remember, what we just went through, population-based studies use a group as the unit of analysis. So the group could be a country, it could be a county, it could be any large group. And the exposure and disease data are both collected at that group level. And they're expressed as averages, probabilities, or per capita. We saw a lot used for different intakes. Whereas individual-based studies are going to use each person, like each one of you in the class, as the unit of analysis. And the individual exposures and disease data are known. We're collecting that. So that gets us to cross-sectional studies, the other design we're going to talk about today. So this is a type of prevalence study. Exposure and disease are measures that are obtained at the individual level. It's one period of observation. And they're both collected basically simultaneously. And there's something here about both probability and non-probability sampling is used. So something like NHANES will go out and try and make sure that all ethnic groups are represented in their study. And so there's not an equal probability for, say, a Caucasian person to get in the study as a Hispanic person, because they want to make sure that the Hispanic people are included. So you can have different ways, and NHANES is one of the largest cross-sectional studies that you'll come across. So cross-sectional studies, just like the ecologic studies, are useful for generating hypotheses that we can later go on and test in other study designs we'll talk about in the future weeks. They're good for intervention planning. It gives us an idea of a snapshot of within a community, what are the diseases, what are the issues that we need to deal with. And it'll give you an idea of the magnitude and distribution of a health problem. So in a cross-sectional or prevalence study, say we want to, instead of this ecologic study I had said, we want to look at the relationship between calcium intake, the exposure, and high blood pressure, the disease. So in a population, say in all of you, I do an assessment of your dietary calcium intake, I measure your blood pressure. That's the snapshot of this class in terms of blood pressure and calcium intake at this point in time. And this disease is really based on prevalent cases. I don't know if you've had high blood pressure all your life or if we just assessed it today and it was the first time it was found, and we don't really care. You're just considered to have high blood pressure. So this is an example, graphic example of cross-sectional studies. So you start with a defined population, you gather data on exposure and disease, and you put people into 4 different categories. They could be exposed and have disease. So for today's reading, what would be this group? Who would you call exposed? What was the exposure? Yes. Right, high levels of trans fats. And what would be the disease? Yeah. Well, adenoma is what they were looking for. So it's people with adenoma. And so people would fall into each of these cells. These would be people that had high trans fat diets, but they didn't have an adenoma. And these would be people that had low trans fat diets, but they did have an adenoma. And this is people with low trans fat diets and did not have an adenoma. So all of this information was gathered basically at about the same time for this whole group. And what you do with this information is you put them into this 4-fold table. And it allows you to look at those people that are exposed and diseased, those that are exposed and have no disease, those that are diseased but were not exposed, and those that had neither exposure nor the disease. And we can really look at this 2 different ways in terms of exposed or not exposed and disease or not disease. In terms of this is everyone that was exposed, this is everyone that has the disease. So we get all the information with this snapshot in time. And with this data, we can calculate the prevalence, going back to the calcium, of hypertension compared in the exposed and non-exposed. So it will be A over A plus B, so it's high calcium. So it's the people with hypertension over all those with high calcium, and then C over C plus D. And this will look at the prevalence of exposure, high calcium, compared in the disease with hypertension and non-disease normal blood pressure. And so all of these are here. And I just want to go on to the graphic where we can kind of see it here. So here you have the prevalence of disease in the exposed compared to the non-exposed. So here's the prevalence of the disease, so high blood pressure or an adenoma, in those people that were exposed compared to those people that were not exposed, or C. And we need to have a denominator for both of these. And so this is all the exposed and this is all the non-exposed serve as our denominators, because we're looking at the prevalence of disease in exposed compared to non-exposed. We can also turn this around and say, okay, instead I want to know what's the prevalence of, say, high trans fat diets in those people with adenoma. So there we're looking at who has the disease and was exposed, so they have high trans fats and they have an adenoma, divided by all the people that have an adenoma, and comparing that to the people that were exposed but had no disease, divided by all the people with no disease. So that's the 2 different ways that you can take in a cross-sectional study the 4-fold table and describe it. Either looking at prevalence of disease in exposed versus non-exposed, or prevalence of exposure in diseased and non-diseased. So if we are going to go about doing a cross-sectional study and we want to end up with all of this information to put in the fourfold table, we need to think about, well, who's our study population? Is it going to be a sample of people or households in a defined geographic area? Is it defined by the study question, an occupational or a regional exposure? Or are we randomly going to sample an area like the NHANES for the United States? So we choose what our study population is, whether it's this class or it's everyone in Washington Heights, everyone in New York City, or everyone in New York State. We can choose whatever the population is. Then we need to go about measuring exposure. We need to understand, well, okay, what were they exposed to that maybe relates to my outcome? You can do this by questionnaires. You can do this by records, looking at medical records. You can do it by lab tests. So if you wanted to know how many of you were vitamin D deficient, we could just do a lab test on everyone. We could do physical measurements, which was like the blood pressure, if we measured all of your blood pressure. And so you can get not only a yes or no to any exposure, but also the duration and when the exposure occurs. So for example, obesity is thought to relate to arthritis. And you may want to look at weight history because you want to think about separating out that you got arthritis and therefore you became obese, or did you have obesity and therefore you were at greater risk of arthritis. So although you're asking all the data at one point in time, you can kind of ask about an earlier time period to try and get at this answer. And so really cross-sectional designs, we use them a lot for factors that do not change as a result of a disease. So something like blood group, so your blood type, whether it's type A or B, all of that, it's not going to change, and that's a good thing to use in a cross-sectional study. One of the things that as we go through is that you also want to think about is the measurement of occurrence of disease. So if I was doing arthritis, am I just going to have a questionnaire and I'm going to ask if you have symptoms or if you've ever had a diagnosis of arthritis? Or am I going to have a rheumatologist here and that's going to actually physically examine each of you and say whether or not you have it? Or are we going to take an x-ray of your joints and try and determine if you have it that way? We try and determine the time of the onset of the symptoms of the disease when possible, but it's all being done kind of by someone's recall. And you can ask whether they ever had the disease or symptoms in the past. And just like we started out the lecture talking about diagnostic criteria, you need to have some diagnostic criteria you're using for this. So am I going to call hypertension in all of you when I measure your blood pressure anything over 130? Systolic blood pressure, am I going to use 140? What am I using as the classification? If I'm measuring all of your vitamin D levels, am I going to say 30 is normal or am I going to say 20 is normal? All of this has to be defined in advance of starting the study. We also need to control for confounding, and so we need to have collected the data for any confounders, because then we can use statistics to try and look at this relationship. So if I was looking at the calcium and blood pressure one in all of you in the class, I know that blood pressure might also be impacted by whether you smoke, by whether what your level of physical activity is. So I want to ask all of that so I can control for it and see whether after controlling for all of that, just like the multivariate models they use in this adenoma study, then we can see if the relationship still holds true. So some of the examples of a cross-sectional study might be a survey of what is the use of smokeless tobacco among high school students. Maybe now we'd look at e-cigarette use or these electronic cigarettes and see what is the use of those. And we can do prevalence surveys of a number of people with asthma in the community. And once we ask that, we can ask another questionnaire and see if anything we ask relates to asthma. And we find, okay, well, one of the things is whether they had a pet. So let's do a study and try and study pet ownership a little more clearly. Looking at congenital malformations across different age groups. They're more likely to occur as a mother gets older when she has the baby, so we could look at some of these with cross-sectional data. But there are limitations, just like the Ecologic study. We are not getting incidence data. We're just measuring you now. We don't know if you've always had it or if how long you've had it. Just like the adenoma, we didn't know whether they had the adenoma for a while. We just assessed it during this cross-sectional study. You can't really study low prevalence diseases. If we were doing something where we wanted to find, say, leukemia, childhood leukemia, I'm not going to be able to do that in a cross-sectional study. There's not enough people that are likely to have had childhood anemia to get at that. And importantly, whenever you do a cross-sectional study, we don't know whether the exposure preceded the disease, and that's called temporality. We don't know the time course of events. Were they exposed and then they got the disease? Or did they have arthritis and therefore they got obese? We don't know which came first. And that is one of the limitations of cross-sectional studies. In addition, for cross-sectional studies, we're only reviewing prevalent cases. So we're not going to get people who die quickly or were cured quickly from a disease. They won't be part of our study because we're just kind of taking a snapshot, and if they've already left, we're not going to get them. All we can really say with cross-sectional data is that it suggests there might be a relationship that needs further study. And there's always an issue, how do you handle treated cases? So I talked about all of you measuring your calcium intake and your blood pressure. Well, what if you don't have hypertension when I measure you, but you pull me aside and say, well, actually, I've been on a drug for 10 years to control my hypertension. What do I call you? Do I call you someone with hypertension or without? All of this should be decided in advance. And the other thing is that the exposure status during this snapshot in time may have little to do with the exposure status at the time your disease began. So say if we're talking about blood pressure and it's based on plaque accumulation and different things that have occurred over years, maybe we really needed to ask about your diet when you were a teenager and not now in your 20s. You know, that's the kind of thing we need to think about. But there are advantages of cross-sectional studies. They are based on the general population, not only those seeking medical care. We usually do these, you know, at the population level. It's a very short time that it takes to do these studies, so they're not that expensive and they're quicker to complete. That's why a lot of people, like my doctoral dissertation, had to do with a cross-sectional study because it's something I could get all the patients in and look at all the data within the time it takes to get your degree. So those are the way that it's done. Now, there are different studies, and in the future lectures, we're going to look at all of these. So the future lectures are really going to look at, if we want to analyze an exposure and disease relationship, how would we do it? One is with an uncontrolled assignment. So we're just looking at observational studies. We're asking people, what is your usual intake? We're not giving them anything. We're not changing their intake. And that could be, if we sample because they have a disease, then it's a case control study. If we sample because they have a characteristic, or we ask everyone questions in the beginning and follow them forward like the Framingham study, that's a cohort study. Or we can do controlled assignment, which is really an experimental study. And the one that we do this most typically is the randomized clinical trial, although sometimes it's a community assignment like with the fluoride-treated water. So with that, what I wanted to do is switch to reading the paper that you had for today. So this was looking at